Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Welcome, CardioNerds. My name is Rick Ferraro, and I'm a cardiovascular imaging fellow at Michigan Medicine and prior cardiology fellow at Johns Hopkins Medicine. And we're incredibly excited to introduce to you our newest series on cardiovascular imaging, a three-part series on all things ATTR, or transthyretin cardiac amyloidosis. We'll be taking deep dives into the biology, diagnosis, and management of this complex and rapidly evolving disease process. Today, I am honored to be joined by Dr. Anna Radakrishnan, internal medicine resident at Mount Sinai Hospital, future cardiology fellow at Mount Sinai Hospital, and tremendous member of the CardioNerds team. Anna, great to be here with you today.
Thanks so much, Rick. So very excited to be here today and be part of this awesome conversation. Today, I have the great pleasure of introducing Dr. Daniel Judge, Edwin W. and Teresa H. Rogers, Endowed Chair for Cardiovascular Research, Director of the Cardiovascular Genetics Program, and the Fellowship Director for Cardiovascular Disease at the Medical University of South Carolina. He received his medical degree at the University of Pennsylvania and did his postgraduate training in internal medicine, cardiology, and advanced heart failure transplant cardiology, all at Johns Hopkins. Dr. Judge is a teacher, a mentor, clinician, and an absolute leader in the field. Dr. Judge, welcome to CardioNerds.
That's very kind of you. I'm thrilled to be here.
So there is a lot that we'd like to discuss today, maybe more than we can cover, but we're going to do our best. And we're going to start by exploring transthyretin amyloid, or ATTR as we'll call it, throughout the rest of the episode, via a case from the CardioNerds clinic. So I'd like to introduce Mr. Paul York Parsley. His friends call him PYP. He's a 68-year-old man with a history of well-controlled hypertension. Over the past year, he's been experiencing worsening shortness of breath, fatigue, as well as swelling in his legs. He initially attributed this symptom to getting older, but they've become severe enough to interfere with his daily activities. He also mentions that he's had numbness and tingling in both hands and recently underwent carpal tunnel surgery on both wrists. During his workup, an echocardiogram revealed severely increased thickness or left ventricular wall thickening, which was initially thought to be due to hypertension. However, his symptoms continue to progress despite optimal medical therapy. He's currently on lisinopril 10 milligrams daily, which had been reduced over the past year from 40 milligrams daily, which Mr. PYP attributes to his reduced salt intake. Dr. Judge, I'd like to start off with a discussion of red flags for cardiac amyloidosis in general. Flashing back to the original CardioNerds cardiac amyloidosis series, inspired in part by your bedside teaching at the Johns Hopkins Hospital Progressive Cardiac Care Unit. And in that series, episodes 7 through 10, if you're able to go to the podcast log, we taught CardioNerds that the most important step is to maintain a high index of suspicion for amyloidosis, and that we need to sniff out amyloidosis based on key cardiovascular manifestations and several non-cardiovascular manifestations, the latter of which vary based on the culprit amyloidogenic protein etiology, whether that's ATTR, light chains, serum amyloid A, et cetera, and it can get more complicated. But to wrap things up, Dr. Judge, can you share your playbook for this generally? What cardiovascular or non-cardiovascular red flags do you look for? What culprit proteins are relevant for cardiac amyloidosis? And how do we apply that playbook to Mr. PYP's presentation?
Yeah, Rick, I think you hit a lot of the main points, which is really great, and just teed it up because clearly this is amyloid. But let me talk through a couple of things that catch my attention in the patient that you just presented. His initials are PYP, so we know where this is going. But I'll start with his history of hypertension, his LVH, and that's exceptionally common. Anybody with longstanding hypertension, poorly controlled, has LVH. And I really always immediately want to know, well, what's the EKG look like? And I don't look for low volts. It doesn't have to be low volts. I just want it to be discordant. So normal volts with prominent LVH or lowish volts with LVH really all fit well with an infiltrative cardiomyopathy, or other things certainly can do it. None of these are specific. You mentioned his bilateral carpal tunnel syndrome, and it reminded me immediately of a grand rounds talk I gave back at Hopkins. You mentioned that time that I spent there, and I'd finished talking about amyloid, and a pulmonologist in the front row didn't raise one hand, he raised both hands. He had braces on his wrists, and he said, "Should I be worried about amyloid?" He had bilateral carpal tunnel syndrome, and of course, I said, it's a common condition, carpal tunnel syndrome, less common when it's bilateral. it is a red flag. It is something in the right context with heart failure, with LVH, with neuropathy that really makes you think amyloid should be under consideration. You asked about some other things. What are the other physical exam or phenotypic or symptomatic findings besides heart failure and neuropathy? One that Rodney Falk really nailed, he found it just with his careful observation, and this is more common in the wild type form, but biceps tendon rupture, which can happen. Again, it's about one in, I think they found 3 in 100 or something like that in their series, but found that a prominent percentage, a little over a third of patients with wild type TTR amyloid had biceps tendon rupture, which always, again, catches my attention. Family history, we published a paper a few years ago that said it doesn't really show up very well because of the poor rates of recognition and diagnosis in prior generations. And that's hopefully going to change over time. But as somebody who loves cardiac genetics, I'm always going to look to family history. It doesn't really provide a lot of clues. So I guess that's where I start, at the bedside.
So the misfolding of the amyloid fibrils really seems to be the key issue here, and different amyloid species preferentially deposit in different tissues to cause end organ injury and dysfunction. Our first step, as has been mentioned, is to maintain a high index of suspicion and really sniff out the telltale red flags. But next, we really must proceed with diagnosis. We will discuss diagnosis in another episode. But Dr. Judge, can you please briefly describe the diagnostic pathway in Mr. PYP's case and others?
Well, number one on everybody's algorithm for making the diagnosis is rule out AL amyloid. For a long time in the amyloid field, we've said AL amyloid is an emergency. And I think that really reflects the faster rates of progression. But it sounds like TTR amyloid is something you can really be casual about. And I try to be prompt in making the diagnosis. And I think having an early diagnosis and early treatment in every single study that's ever been done, the earlier we start therapy for TTR or for AL, the better the long-term prognosis. So back to what do I do next? Checking for a monoclonal gammopathy. Remember, serum protein electrophoresis, urine protein electrophoresis. So sometimes we'll not see an M protein in the serum, but we'll find it in the urine. You have to do both. And not just electrophoresis, because that'll tell you, just amounts of protein, but it isn't as good or as sensitive at finding a monoclonal protein. So immunofixation electrophoresis, both serum and urine. A question that often comes up is, do I need a 24-hour urine? And I think that an aspect of how Epic or order systems work, and that's always one of the questions that's asked when you're putting in the order. And the answer is no, you just need a random urine. 24 hours is more sensitive, and it's very rare that I'll do that in my diagnostic evaluation. And then free light chains. Free light chains are kappa and lambda, and checking those levels is important, looking at the ratio. Remember that kappa is a little bigger than lambda, and if you have renal dysfunction, you're not going to filter it out quite as well, and so your kappa levels rise as your renal function worsens. So a mild increase in kappa to lambda ratio, is not a sign of concern, but if you start seeing elevated lambda, even if you don't have an M protein detectable, you should think about AL amyloid. You should really have a greater suspicion and do something more diagnostic. A few years ago in the amyloid community, we tried to change the acronym MGUS. We've all heard that, monoclonal gammopathy of undetermined significance. I think when you're thinking about amyloid, a better way to look at it is must get under the skin, right? You've got to do a biopsy if you've got an M protein. If you've got any suspicion for AL amyloid, you need tissue to make the diagnosis. So that's where, in my mind, an endomyocardial biopsy is your best bet. Others would argue that maybe a fat pad aspirate or biopsy, even, which is better, will make the diagnosis. The rates of finding amyloid are low there. Aspirate is minimal invasive, and you get what you put into it. If it's very easy to get and it has a very low diagnostic yield, I don't think it's worth it. An endomyocardial biopsy, as a heart transplant cardiologist, I think that's a relatively straightforward, easy, routine procedure. So that's usually where I go when I've got any concern for AL amyloid. If we don't have that, then we're back to this guy's initials, PYP. And I think that's one of the things that's accelerated the recognition, the diagnosis of TTR amyloid, the ability to non-invasively image and find TTR amyloid on the basis of PYP scan. You have to do the PYP scan correctly. Now, I'm not an imager, but if you simply look in the old-fashioned way with planar imaging and see an increased ratio on the heart side versus the contralateral lung side, you may get fooled with blood pool uptake, and that's really a problem. To do the test, you should do it with SPECT imaging. You should be able to localize PYP uptake to the LV wall, to the myocardium itself. If you have that, great. Then you've got your answer. And then the last thing on the list is a TTR genetic test. And that's often forgotten. But if you've come up with TTR amyloid, even if it's an older man and you're saying, well, it's almost certainly wild type disease, you really should do the TTR genetic test to know if it's hereditary or genetic.
Thank you so much, Dr. Judge. That's really spectacular and tremendously helpful. I will say that Doing a cardiac imaging fellowship right now, that's something I think about a lot. And we're actually going to talk about that in a second. But that's a great point that you made about the heart to contralateral lung ratio really not being as accurate, and that SPECT imaging is really how we diagnose this now. And that is something we're going to talk about in an episode coming up dedicated to diagnosis. So everyone sit tight for that one. But in our case, Mr. PYP has been diagnosed with ATTR cardiac amyloidosis based on a negative gammopathy panel and a positive PYP scan with grade 3 uptake. He also had a heart to contralateral lung ratio of 2, which would be positive. But again, grade 3 uptake is what nails it for us. Genetic testing reveals a Valium 122 ILE mutation. What are the implications of genetic versus wild type ATTR cardiac amyloidosis? And how does genetic testing change the picture for Mr. PYP here?
Yeah, great question. Let me start with the first part of that, which is the actual gene change, because in the amyloid field, sometimes people say, well, amyloid, isn't that a new thing? Isn't that something that's only recently been recognized? But no, it's been around for like 100 years. It was described in the 1920s, and I think it was a German paper. And we've known about transthyretin, also called prealbumin, for an awfully long time. It has nothing to do with albumin, other than being a small protein. On an electrophoresis of blood, the protein prealbumin, or TTR, comes off the gel more quickly than albumin, the most important protein, the most prevalent protein in the serum. So the numbering of the protein was initially done by sequencing the protein, and the circulating protein is the mature form, missing the first 20 amino acids. And that's why the V122I mutation on a genetic test report, if the laboratory is following proper genetic numbering, they would call that V142 or valine 142 isoleucine. And that's true of all the different common variants that have been recognized. V122I or V142I is relatively common among African Americans. 3.4% carry that genetic tendency to TTR amyloid. Additionally, there's other variants that are common in different regions. V30M is the most prevalent in terms of the diagnosis of hereditary amyloid polyneuropathy. More common in Portugal, more common in Brazil, more common in Asia. We see it in the US, but a little bit different phenotype. What does it mean? Well, it means a couple of things. First, you're more likely to have neuropathy if you have most of the hereditary forms. Some are really very neuropathic in their manifestation. V30M in certain regions and other gene variants that, for whatever reason, affect the nerves more than the heart. That's a complete unknown right now. But back to the heart, as a cardiologist, we're all cardiologists, we're thinking about that. The disease progresses more quickly, more aggressively. That's the main implication for the patient. It may open the door to additional therapies, and we'll get there. Additionally, it's got great implications for family members. Right now, I think that's the biggest focus. When I'm talking to someone about this, they're often an older person, and they often have children with them or that they've been in touch with, and that's their first concern. What's the risk for my family members, my siblings, my children? Will they get this? Are they genetically predisposed?
This has all been so very incredibly helpful, Dr. Judd. Thank you for your time and teaching here. And you actually provided a very nice segue to my next question. So based on what we know of the biology of ATTR cardiac amyloidosis in Mr. PYP's case or others, like you mentioned, we're going to do a whole episode on this. But what therapies in this case might we be thinking about reaching for?
Well, Anna, I'm going to start with answering that question by the pathogenesis. And, I think we called this ATTR biology or ATTR cardiomyopathy biology. And I think that's one of the hardest questions to answer. When someone says to me, well, why do I have this condition if it's TTR amyloid that we're talking about? And we have no idea, right? Frankly, for wild type disease, I and several other groups around the world have done genetic testing of, exome sequencing and all the other genes. We haven't found anything, and the absence of publications is simply because it's hard to publish a negative result. What other factors contribute to that condition? The only thing that I can point to, well, I guess there's a couple of things I can point to. One, we know chronic inflammation lowers your prealbumin levels, your TTR levels, and lowering levels of the protein. And we'll come to that in the therapy part of it. But if it's done through inflammation or through a gene mutation or through other approaches that aren't therapeutic, it seems to be pathogenic. It seems to be contributory in the pathogenesis of particularly wild type TTR amyloid and probably the hereditary form. Whatever causes the wild type is likely a modifier of the genetic form. The other way to think about it, at least when I remember being at an amyloid support group meeting in Chicago many years ago, and there was a group of people, all of whom had wild-type TTR amyloid and cardiomyopathy, and I asked them, how many of you have run a marathon? And there were maybe 20 that I was talking to, and 8 of them raised their hands and said, I've completed a marathon, and several had completed many marathons. And it's really back to something that we see in practice with these patients, that they tend to be exercisers. Now, I'm not saying exercise is bad, and I don't want to go on the record for that other than for ARVC, another favorite disease of mine. But for TTR amyloid, there's a clear association. It may explain Matt Maurer's recognition of increased hip and knee replacement. It's certainly something that we see in amyloid. But what is it about exercise? Is there cleavage of the protein? And that's something that's been raised as a possibility that makes it less stable. Well, back to therapies, I guess understanding the pathogenesis is important for therapies. One of the main things that we do know, and this gets back to Jeff Kelly's pioneering work 20 years ago to recognize that in the setting of a hereditary form of polyneuropathy in TTR, a E30M mutation in some people was associated with almost no disease. And he did what seemed complicated at the time and is very simple now, is he just looked more closely at the gene, at the protein, and he found a gain of function variant called T119M and showed that by this trans stabilization with the other copy of the gene creating a 50% of the protein that's produced that is able to stabilize the unstable form and form a more stable tetramer, that was able to either delay or prevent the onset of TTR amyloid. That really made things possible in my mind, or at least that was the opening door to say that if genetic complementarity can treat this condition, that maybe pharmacologic complementarity or stabilization of the TTR complex could work for this disease. So that led to Jeff's discovery and development of tafamidis, the first approved therapy for TTR amyloid. The same concept was something that John Burke at BU used. He actually did this study on an R01 from the FDA. He studied diflunisal to stabilize the TTR tetramer, and it works. It's just not very potent. And it's got some challenges as a nonsteroidal anti-inflammatory drug. It's not something we want to use for patients with heart failure, but it works. And that's number one in terms of strategy. I'm personally excited about a drug that I've had a long time working with called acoramidis, now Attruby, and it's the second TTR stabilizer FDA approved. And gosh, that one really seems great and would love to come back another day and talk more about that one. But we're excited about some of those results. The other approach to treating this condition with FDA-approved therapies right now, a handful of medications that will turn off the gene. I mentioned that already. If you don't make the protein, you can't deposit the protein as amyloid in your heart and your nerves or anyplace else. And so it's very appealing. It's the lingering doubt in the back of my mind when I talk about it is, gosh, this protein has been around forever. It's something that all mammals and most vertebrates, I think, it goes really back through much of evolutionary biology, have this protein, and it's conserved. It's highly conserved. And minor changes in the protein can really mess it up. So what does it do? We think it's a redundant protein, a protein that's not necessary. If you knock it out in a mouse, the mice seem okay. They have some reproductive deficiencies, but that shouldn't affect most of our patients with TTR amyloid. But what if we get rid of this gene or this protein? Are we causing trouble? We don't know right now, but it seems to work. So the idea is turn it off as much as possible or stabilize the protein as much as possible. Back to, do we make the protein higher or lower? The answer is yes. Both have been proven to work. Can both work together? Who knows? So far, the limited data that we have don't look so promising, but it's one possibility. So those are the approaches to treating TTR amyloid right now.
Thanks so much, Dr. Judge. That was really just an incredible overview of your thought process, which I find really a privilege to listen to, but also the therapies in general. As a follow-up to that, I would love to discuss with you a little bit more about promising therapies or additional treatments that might be on the horizon. And one particular question I wanted to ask you is about CRISPR-Cas9. And you had mentioned that this mutation or this protein is relatively preserved. And is that something that's viable? I know there have been some small studies, but would love to hear your thoughts in general.
Well, so I'm excited about CRISPR. My patients are excited about CRISPR, and I say to them, hey, we could potentially give you a one-time treatment that will cure you and you can't have the disease anymore. They are, taking out a pen and saying, where can I sign up? It's got a ways to go to prove the safety, I think, predominantly because the efficacy is pretty well established. Mariana Fontana showed more data at AHA in 2024 that really was exciting, that shows a single treatment with CRISPR-Cas9, not to correct, but to remove the TTR gene permanently. Both copies removed from the liver, doesn't get into the brain. So there's some production of TTR in the brain, and we don't really know what the implications are there. But back to whether this is a good idea, I hope so. I advise it for my patients if they're willing to try. I think it's exciting, and I hope where we're going in the field to be able to recognize a genetic condition and to treat it and to start early and to do so effectively and safely. But like I said, it's not FDA approved, and so it needs some further data, more time, more patients to prove both safety and efficacy. You asked about other treatments. So CRISPR's number one on my list, but that doesn't mean I'm not looking at a handful of other medications that are following the same strategy, which is depleters, essentially is what they're called right now, or antibodies that target amyloid protein. If you or anyone has heard me give a lecture on this in the past, and I've said this, I've stood up on a podium and said, that seems like a bad idea to me because you're targeting the immune system to fight a dense protein that's really densely adherent into the myocytes of the heart. And do you really want to activate complement and cause myocarditis to remove this protein? That sounds like it's going to cause trouble. And that was my mantra about this idea until I heard and read and discussed with my colleagues at the London Amyloid Center. Mariana Fontana led this study as well with Julian Gilmore. They found 3 people whom they'd followed in this very large amyloid center who surprisingly had resolution, spontaneous resolution of their TTR cardiac amyloid. And they looked, they couldn't believe it. They had to go back and review the echoes, review the MRIs. They had plenty of data. They had lots of biomarker data. They even had ECG data that were getting better. And if it were 1, they might have thought, well, maybe we missed something up, but they had now 3. And then they looked in the blood of those patients and found a polyclonal antibody, not the monoclonal antibodies, but polyclonal antibodies target amyloid, TTR amyloid deposited in the heart and appear to be successful in removing amyloid. So what does this mean for pharma? Well, a handful of companies are all doing similar strategies with different antibodies to target amyloid in the heart, mostly using, and all of that I'm aware of, using monoclonal antibodies that will ideally remove the amyloid from the heart. So maybe it's a one-time treatment, maybe it's recurrent treatments, maybe it's treatments in conjunction with a stabilizer or a silencer. We don't really know yet where that's going to go, but that's certainly on the horizon right now.
That's great. And so interesting to hear about your experiences, but also your insights in this very exciting and clearly actively evolving space. This has been a phenomenal discussion. Dr. Judge, as we start to come to a close a little bit, what are your main takeaways regarding the biology of ATTR cardiac amyloidosis? And what do you want our listeners to really take away from this conversation today?
Yeah, well, first, I'm glad that it's getting a lot more attention. And I think my patients who say to me, it's not a rare disease anymore, are right. It may never have been a rare disease, but our recognition is good. Our ability to treat it is good. But we shouldn't be satisfied with where we are right now because every day I'm seeing someone who's got amyloid and it's slowly progressing or it's already caught them in a pretty bad position. And we have to be able to do more. So that's first on my list. And second, in my mind, and I'm going to go back to what I mentioned before, we don't understand wild type TTR amyloid. And understanding that condition should help us to be able to develop better therapies or maybe non-pharmacologically prevent this. Maybe there are other activity or lifestyle things that we can do differently that will lower the incidence of this condition.
That's great. Thank you for that. And to close, we'd like to ask you a question we ask all our guests here at CardioNerds. What makes your heart flutter about ATTR cardiomyopathy?
Yeah, it's a great question. And I think what drew me to the field, I'm going to point to 2 things. First, I have been struck over my entire career, with very rare exceptions, at how many of the patients that I care for with this condition are just nice people. And bad things happen to nice people. We've all learned that in medicine. And whether there's something related to the amyloid into their brain or whatever it might be, patients with this condition tend to be really nice, tend to be people that I enjoy taking care of. And second, it's the combination of 2 of my favorite things: heart failure. I'm a heart failure cardiologist, and genetics. Not all of it's genetic, but the translational research that goes into this disease, the amazing technology that's led to amazing improvements over the course of just a few years has been really one of the things that makes me excited, makes my heart flutter about ATTR cardiomyopathy.
So thank you so much, Dr. Judge. This has been really a tour de force on ATTR cardiac amyloidosis and cardiac amyloidosis in general. And I say it's a really special privilege, having done a lot of training at Hopkins myself and having heard so much about you during my training. It's a huge privilege to speak with you. And I think so many CardioNerds are going to benefit from this discussion. So thank you so much for your time and really looking forward to these developments as they progress.
Very kind of you. Thank you for having me. I appreciate it. Anna, thanks for also your involvement in this. It's been really great to check in. And Dan, always great to see you. Please tell Ahmed I said hi.
We're happy to always learn from you, Dr. Judge. So with that, thank you all. Have a wonderful night.
Yep, you too.
Thank you so much for tuning in to this CardioNerds episode. The audio editing for this episode was performed by me, Julia Marques. I am an intern in the CardioNerds Academy House Thomas, and I'm a 6th-year medical student at Albert Einstein University in São Paulo, Brazil. Check out the episode page for show notes and references. If you found this episode or the show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episodes. And now, my friends, it's time to make like an S2 and split.
Hey everyone, do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you're shaking your head yes, then keep on listening, because Freed AI is a medical scribe on a mission to free clinicians everywhere. Freed AI listens, transcribes, and writes medical documentation for you. So just imagine leaving your office at the same time as your last patient. Now, wouldn't that be delightful? Freed AI is HIPAA compliant, secure, and takes less than 30 seconds to learn. Team, artificial intelligence cannot replace you, but it can do the administrative work that will allow you to spend more quality time with your patients and enhance your personal work-life harmony. So get back to doing what you love, helping your patients, and let Freed AI do the rest. Check out www.getfreed.ai to learn more.